From the JAMA Network, this is the JAMA Medical News Podcast, discussing timely topics in clinical medicine, biomedical sciences, public health, and health policy, featured in the medical news section of JAMA.
This is Jennifer Abbasi for JAMA Medical News. My guest today is Dr. Joanna Chikwe, chair of the American Heart Association's annual Scientific Sessions Conference, which is taking place as we speak in New Orleans. Dr. Chikwe is chair of the Department of Cardiac Surgery in the Smidt Heart Institute at Cedars-Sinai Medical Center in Los Angeles. And she's joining me to discuss clinical research highlights from AHA's flagship meeting. Welcome, Dr. Chikwe.
Thank you very much, and it's a genuine pleasure to be talking to you.
As we're recording, today is the last day of the conference. How's it going?
It's been amazing. I think the general feedback is that it's felt energized. The science has been practice changing. There have been some truly wonderful talks, including by a phenomenal Nobel laureate, and going across 4 days was really welcome.
Wonderful. Okay, so let's talk about some of the interesting science that's been presented at the meeting. We'll start with research on coffee consumption and atrial fibrillation. A clinical trial compared AFib recurrence after successful cardioversion in coffee drinkers who were either randomized to continue drinking coffee or to abstain from coffee and caffeine for 6 months. And this study was simultaneously published in JAMA. Could you give us some context? So why is it important to look at coffee and AFib, and what did we learn?
For a very long time, most patients who are at risk of atrial fibrillation or being treated for it have been advised to abstain from caffeine. And it's really fantastic when investigators actually come up with a study that addresses assumptions like that. And I think most people in the room were pretty surprised by the results.
So can you tell me about those results?
Surprisingly, it seems that if you allow people to continue drinking coffee, it doesn't seem to make a negative difference to their chance of having atrial fibrillation. And at least in this study, the coffee drinkers had lower rates of recurrence of atrial fibrillation.
So is it important that these patients had undergone successful cardioversion, meaning electric shock to the heart to restore normal rhythm? Meaning, is this applicable only to that group of patients?
That's a great question. And I think if you're trying to decide what to tell the patient sitting in front of you, that's important context. That said, it certainly gives me increased comfort to let my postoperative patients know that they can probably have a cup of coffee if they want one. I have a lot of people looking very worried at each time I say this. You probably shouldn't drink anything other than naturally caffeinated drinks in this context. That means coffee or tea, and not excessive amounts of it.
Okay, wonderful. Another trial presented at the conference examined a single pill combination therapy for heart failure with reduced ejection fraction. According to the authors, this is the first trial of a polypill approach for HFrEF, and it looked at 3 medications in 1 pill. The idea, of course, is that simplifying treatment could improve medication adherence and, in turn, outcomes. So what did we learn?
So that was an impressive idea, and the concept of a polypill is obviously not new, but looking at it in this patient population and specifically targeting heart failure is, and the finding that there was a modest improvement in ejection fraction in the patients that were randomized to polypill perhaps suggests that the improved compliance in that kind of therapeutic deliveries is associated with better outcomes.
Okay. And are these pills available yet? I don't think so.
I don't believe they're available yet, but hopefully data like this will support companies that are thinking about how best to really package proven therapeutics in a way that enhances compliance and patient outcomes.
The next 2 studies we'll discuss were trials of PCSK9 inhibitors. The first compared the risk of major adverse cardiovascular events in people who received either the PCSK9 inhibitor, evolocumab, or placebo. And unlike previous studies, this one focused on people with heightened cardiovascular risk who had not yet had a heart attack or stroke. So it was a primary prevention trial. Can you talk about this one a little bit?
Yes. So evolocumab is a large study, 13,000, I think, patients, and looked at a method of delivery of this therapeutic agent, which is a every 2-week injection. in patients. And essentially, it's a very compelling finding. These were patients that had hyperlipidemia that was refractory to standard medical therapy, and this modality had a significant impact on the chances of them having an adverse cardiovascular event during the study period. So it is quite a supportive piece of data, and I think that was met with a round of applause during the late-breaking presentation. It was really impactful piece of work.
And why do you think that is? Why are clinicians excited about this?
Because it's addressing an unmet need in a large, important population of patients that have failed conventional modalities. You may be entering an age of therapeutic agents that literally prevents atherosclerosis and coronary artery disease, as well as vascular disease. So it's an important study.
Amazing. Okay. Staying with this medication class, another trial looked at the LDL lowering ability of an oral PCSK9 inhibitor in people with familial hypercholesterolemia. The currently available PCSK9 inhibitors are injections. So can you talk a little bit about this trial? And I'll mention that it was also published simultaneously in JAMA.
So you got two really great studies there, and you're absolutely right. They complement each other in that you're looking at a similar mechanism of action. But the second study, HFrEF, looked at, I think it's 300 or so patients. It's not by any means as large, and they all had familial hypercholesterolemia. So it's a slightly different subset of this challenging patient group. And it wasn't a clinical endpoint. It's just a reduction in LDL, but during the study timeframe, which I think was 24 weeks, 60% of patients had a significant reduction in their LDL levels. So again, it's an important signal that there's a new piece of armor in the armamentarium for a very challenging subset of patients.
Okay. Now let's turn to a topic that's always popular, which is vitamin D. A trial investigated whether personalized vitamin D supplementation could prevent cardiovascular events in people who had had a heart attack. Vitamin D supplementation compared with usual care did not reach the primary outcome of death, heart failure, hospitalization, or stroke, but it did appear to reduce the risk of having another heart attack. So can you tell us a little bit about this trial and the findings?
So this was a single-center study following patients that, as you said, had acute coronary syndrome out to a maximum of about 6.5 years. The median was about 4 years. And I think that the findings suggest that there may be value in knowing what patients' vitamin D levels are and optimizing them. Is it clear that taking vitamin D supplementation could reduce your risk of cardiovascular events long term? Much less clear from this data. So more to follow.
Right. Yeah, what I thought was interesting about this trial was that they measured blood levels of the people randomized to receive vitamin D. And they continued to measure them and adjust the vitamin D supplementation. And some of the supplementation was quite high in order to reach the target levels. So I think this trial was a little bit different in that regard, that it was a very personalized intervention. So
very personalized. You have to ask yourself how feasible and reproducible would that be in real world practice?
Right. That's always the real question, right? Okay, so more to come, hopefully, on vitamin D. That's it. Thank you so much, Dr. Chikwe. I hope you enjoy the rest of the conference, and thank you so much for making the time for us.
Thank you very much. Genuine pleasure speaking to you.
That's it for clinical highlights from AHA Scientific Sessions. I'm Jennifer Abbasi, Director of JAMA Medical News. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening, and join us again next time.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.